Great. Emily,
Wonderful
do you
to
think
see
we
everybody.
can start now?
I can. I know there's still folks joining us, but in the interest of time, maybe we can get things started. So good afternoon, colleagues. It's great to see some familiar faces, but also some new faces as well. For those of you I haven't met, my name is Emily Grunwald, and I'm the President and CEO of Children's Healthcare Canada here in Ottawa. I'm joining our call today from the unceded lands of the Algonquin Anishinaabe peoples. And as an organization dedicated to improving health systems for children and youth in this country, we recognize how much work remains to address the significant gaps in access to healthcare and to improve the health and well-being of Indigenous children and youth. We also acknowledge the wisdom of knowledge keepers, elders, and traditional teachers who can help us guide the path forward. Children's Healthcare Canada, we are a national association. We represent Canada's 16 children's hospitals, as well as community hospitals, rehabilitation centers, home care, palliative and respite agencies that serve children and youth across the country. Our members span the full continuum of care, giving us a unique perspective on the health systems that serve over 8 million children and youth in Canada, a population that continues to grow. In collaboration with Senator Moodie, it is my pleasure to host our discussion today on a very timely issue, a crisis we are facing in children's healthcare. Where Canada once ranked amongst the top OECD countries with respect to children's health outcomes, the 2020 UNICEF report card reveals Canada now stands worlds apart from other rich countries when it comes to providing healthy childhoods. Canada's standing has slipped to 30th of 38 countries with respect to children's physical health and 31st of 38 countries with respect to their mental health. Relative to our wealth, Canada punches far below its weight when it comes to kids' health. Today, we're meeting in the midst of a particularly difficult viral season, which is having devastating impacts on children, their families, and our healthcare systems. From coast to coast, children's hospitals in particular are experiencing historic volumes of very young, very sick patients visiting their emergency departments. Compounding the issue, parents continue to grapple with the lack of availability of common over-the-counter medications to treat symptoms of respiratory illnesses, which show no signs of abating. Across the country, the story is remarkably consistent. Record numbers of children visiting emergency departments, record numbers of admissions, record acuity of patients being admitted, record wait times for time-sensitive surgical interventions, record staff shortages, and mounting public frustration. Canadians imagine a healthier future for their children. Children's Healthcare Canada, in partnership with the Canadian Pediatrics Society and the Canadian Association of Pediatric Nurses, released a call to action on National Children's Day, encouraging the federal government to work closely with provinces and territories to make children a priority. This strategy would enable better beginnings by prioritizing maternal and newborn health to give families the best start possible, advance precision health and wellness through world-class care for very sick children, and enabling children living with neurodiversity, disability, and chronic disease to transition from vulnerable to thriving. Before I pass the baton to Senator Moodie, I want to thank you again for your time and attention today. The challenges before us are complex and they are urgent. Measurably improving the health of Canada's kids is everybody's business and will require an all hands on deck approach. We hope our conversation today is a catalyst for action and change because every day matters in the life of a child. Senator?
Thank you, and good afternoon, everyone. As I begin, I want to also acknowledge that I'm joining you from Toronto, the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. Honorable Senators, members of Parliament, and staff members, welcome. Thank you for joining us. In the past few weeks, we have seen our healthcare system put under historic levels of stress. 9 days ago, McMaster Hospital hit 140% admission due to high spikes of respiratory illnesses. Montreal, the emergency department at Ste-Justine, operating at 300% occupancy. BC Children's, amongst the many hospitals forced to set up emergency operations to allow themselves to manage their resources. Hospitals, especially pediatric centers, have had to make really tough decisions. As a pediatrician and neonatologist for decades, I know this is a result of years of failed policy. For many years, we have starved our healthcare system, making it impossible for it to respond in critical times such as these. I also know that in the middle of this chaos, there's a lot of fear and worry about what this all means for our communities, for our healthcare workers, for our children, and for our grandchildren. And I've been fielding questions, as I said earlier, from colleagues who are grappling with their issues and who are trying to understand what they can do. In this session, we've invited folks from across the country. Each and every one is committed to serving our communities well and representing their best interest in Ottawa. This is why I connected with Emily from Children's Healthcare Canada to organize this session so that we can enable parliamentarians to become well informed about the issues that we're facing. So now I want to move in to introduce our panelists. Our first panelist, Dr. Fatima Kakkar, is an infectious diseases pediatrician at the Research Center of Ste-Justine, as well as assistant professor in the Department of Pediatrics at the Université de Montréal, and a pediatric infectious disease consultant also at Ste-Justine. Dr. Ronni has served as president and CEO of the Hospital for Sick Children in Toronto, Canada since May 2019. He first joined SickKids in September of 2012 as the chief of the Division of Clinical and Metabolic Genetics, co-director of the Center for Genetic Medicine, and senior scientist at the SickKids Research Center. Dr. Katharine Smart is a pediatrician in Whitehorse, Yukon. Her work is centered on developing collaborative partnerships with community and government services to serve marginalized children using a model of social pediatrics. She's a past president of the Canadian Medical Association. And finally, Dr. Antonia Stang is the head of pediatrics at Alberta Children's Hospital. Her research has focused on pediatric emergency medicine, quality improvement, and outcome measurements, emergency department efficiency and flow. So I'm so excited to welcome Drs. Kakkar, Cohn, Smart, and Stang with us today, and I want to thank you all for making time. I also want to acknowledge and welcome and thank Globe and Mail columnist Andre Picard. Everyone knows Andre. He has been a champion for children's health, a clarion voice on the issues our healthcare system faces for many decades. He's the author of 5 best-selling books, recipient of numerous awards, including being named the first public health hero by the Canadian Public Health Association, champion of mental health by the Canadian Alliance on Mental Illness and Mental Health, and received the Queen Elizabeth II Diamond Jubilee Medal for his dedication to improving healthcare. With those short introductions, I want to hand over the floor to you, Andre, and thanks again.
Well, thank you, Senator Moodie, for that very kind introduction and for organizing this panel today. Very timely and very urgent issue, as we heard in the introduction. I want to encourage people. I'm going to ask some questions of our panelists, but I want to encourage everyone in the audience to join in, to type in your questions in the chat. We were going to do them live, but I'm afraid I'd miss your lifting of the hands because I can't see everyone. So if you want to type them in the chat, évidemment, vous êtes bienvenus de demander vos questions en français. On peut faire de la traduction simultanée en passant. So if I could, I'd like to get right into it. I'd like to start with you, if I could, Dr. Fatima Kakkar. Can you give us some context about what's going on out there right now? This triple-demic, we're calling it in the media, RSV, influenza, COVID-19. Why are so many kids getting sick all at the same time?
Well, thank you, Andre. And I'm so glad we're actually talking about this right now because it's what we've been facing in hospital these last few weeks. So the number one thing that's driving hospitalizations right now is this surge of respiratory viruses that's unlike anything we've actually ever seen in pediatrics at this time of year. And this surge is first being driven by this virus called RSV, respiratory syncytial virus, which in us adults can cause a common cold, but it can be really severe in infants and newborns, and especially the first time you get it. And so what's happening is that there are multiple cohorts of children, at least 2 to 3 years worth, that are getting RSV for the first time. And with 1 or 2% of them needing hospitalization, those numbers add up to thousands across country that are being affected. and requiring hospitalization, sometimes just regular oxygen, but sometimes needing ICU support. And then in addition to RSV, we unfortunately have an upward of influenza. Influenza has made an appearance for the last 2 weeks. And now we're really concerned about what this can do in pediatrics, because it's a virus that's known to cause complications and can be quite severe in young children. Added to that is this other category of viruses. So adenovirus, parainfluenza virus, these regular respiratory viruses that are circulating at high numbers as well, with a little bit of COVID thrown in. And luckily, kids haven't been as severe with COVID, but there are still some hospitalizations. So we have really 3 major groups of viruses, and children are getting one after the other, and that's leading to this surge of hospitalizations.
And I often hear these people saying, oh, well, these are just colds. But a lot of kids, as you said, are getting quite sick. They have to be hospitalized. Some are even on respirators.
Absolutely. And I think it's important to realize that these are the youngest kids when they're getting this infection for the first time. And, even as of last week, nearly half of the children in our ICU were due to these common colds, these respiratory viruses. So it can really vary from child to child. But for some children, it can be very severe. For some children, it can even be deadly.
Right. Dr. Ronni Cohn, if I could turn to you, there's a lot of sick kids out there. We all know this from the media coverage, but can you give us a sense of the impact on a hospital like yours? I know other hospitals are in a similar situation.
Yeah, thank you, Andre. And I think what's important to understand is that all of the numbers you see reflected in the media, whether these are emergency room volumes or general volumes in the pediatric ward and ICU, they're all interconnected. So, and I know that words like historic and crisis have gone from signal to noise over the last 2.5 years, but it is kind of historic what we see right now. We see incredibly large numbers of children coming to the emergency room, and many of those children then requiring admissions either to a regular hospital bed or to the ICU. And I think what my colleague Fatima just mentioned, what we have seen over the last 10 days is a particularly high number of children on a ventilator in our ICU who actually don't have any underlying medical conditions. We are used to seeing children at SickKids who often have complex medical conditions, but now in addition to those, we are seeing a number of healthy children, previously healthy children, who are being admitted. Now, that is the current crisis of here and now. But I think what's really important for everyone, please, to understand is while we are working together as a pediatric system in different regions like never before to make sure that there are no sentinel events happening in children, there's another crisis that we have been speaking about before that is just going to further exacerbate it by children who don't have access to timely surgery, who don't have access to timely diagnostic imaging. That was already exacerbated throughout the pandemic. And now many of us, if not most of us, have to reduce these services again. So I think it's going to be really important, as tired as everyone is hearing about crisis. We are dealing with the one of here and now. We'll get through it, but we have to think about the one that's just waiting to further escalate, unfortunately, over the next few months as well.
And I've been doing this for a long time, as you have. We've come to accept hallway medicine for adults, delays in surgery for adults, but this is unprecedented for children. We've never seen this.
We have never seen numbers like this at our hospital, and to tell you the truth, even nationally. And I think what's important to understand for all of you, please, is there are no elective surgeries in children. A child who requires a procedure requires a procedure. And every day this child is waiting for the procedure to happen, it could potentially have negative consequences for the rest of their life, because children go through this developmental stage through a process of years, which makes it very different than the problems that the adult healthcare sector is dealing as well.
Great. Dr. Antonia Stang, thank you for joining us from Calgary at Alberta Children's. I wanted to get a sense from you, was any of this predictable or preventable, or is this all a big surprise to us?
Well, I think some of this crisis existed before COVID. You know, I remember in 2019, before COVID hit, having similar conversations about the capacity we were seeing in our emergency departments in our children's hospitals. So we have a problem that's layered on top of a foundation that was already shaky. And part of the challenge for us in pediatrics, different than in adult hospitals, is that when we have a large number of sick children who need either emergency department or intensive care, adult hospitals can do what they call load level sometimes, meaning when one hospital is full, they can shift to another. Because of the specialized care that children need, children's hospitals can't do that. So when the hospital gets full, when the ICU gets full, our emergency departments get full. And that's happened in adult medicine for years, but we're just now beginning to see that impact in pediatrics and what that means for families waiting extended periods to move into a hospital bed and waiting extended periods in a waiting room. We can all imagine what it's like with a really sick child to be waiting upwards of 12 hours in a crowded waiting room. And this is a problem that's not new. It's just been exacerbated by this perfect storm that we're seeing today.
But we are seeing, I don't know if it's officially load shifting, but we're seeing teenagers go to adult hospitals. Again, something we've never seen for many years.
Yeah, that's pretty unprecedented. And although we can do a little bit of that, it's really hard. And so that idea of shifting some of our older kids to adult hospitals takes a little bit of the edge off, but not nearly enough. And so we're very limited in that kind of capacity shifting that we can do in children's hospitals.
And I know a lot of our coverage in the media is focused around Ontario. Well, we know Toronto is the center of the world. Is the situation as bad out west in places like Vancouver and Calgary and Edmonton?
Absolutely. I mean, I can speak for sure for here in Alberta, we're seeing record numbers of emergency department visits, record numbers of sick kids, and record number of patients waiting extended periods in our emergency department. So this, what we're seeing out east, we're seeing just as much on the west. Maybe a little bit, a few weeks behind, but we're definitely seeing it.
Okay. And Dr. Katharine Smart, welcome. Thanks for your patience while we got to you. Now you work in the Yukon, you work in BC, but outside of the big cities. Are we seeing the same problem in rural and remote areas? Are there different issues? I can imagine in some ways it's much worse.
Yeah, thank you. No, it has been really extremely busy for us as well. We're also seeing the surges. I was just on service 2 weeks ago in the Yukon, and I admitted more children to the hospital in a week that I was on call than I ever have in the last 5 years of working there. I think we have some unique challenges in rural and remote areas. Of course, you know, our staffing is much different. We have one pediatrician on call for 7 days in a row in the Yukon, 24 hours a day. So when we see these types of volumes, you know, for me, for the first 40 hours I was at work, I slept 1 hour because I was dealing with critically ill children throughout the day and night. We're also dependent on Medivac services. When we do have critically ill children that need to be transferred to children's hospitals, those are no longer available. So now we're also having to provide our own Medivac services to move children to children's hospitals. And this is, again, that one pediatrician who's trying to deal with outpatient medicine, care for sick children in the hospital, Medivac children to higher levels of care. And this is an issue throughout rural and remote parts of Canada. You know, one of the major differences in pediatrics, of course, is those specialized services, particularly intensive care services, are only available at children's hospitals. And those are few and far between when you look at the geography of Canada. So when we're in Whitehorse and we have an intubated or ventilated child, we're trying to care for that child and move them to that higher level of care. And that is becoming increasingly challenging. And of course, as the hospitals are more full and the teams are more challenged for time and space, and the Medivac programs are stretched, we're often left waiting with these very, very sick children in very low resource environments, sometimes for very extended periods of time. So these surges for us are very challenging to deal with. We just do not have the redundancy or depth of staff. We also don't have the nursing supports or other experts in child health that you see in children's hospitals. So again, this is often resting on the pediatrician to provide all those services. And this would be the case, really, I think, in any sort of rural community that has a pediatrician across the country. So I think you're going to be hearing a lot of quite stressful stories from people that work in environments like I do. We're always very grateful for the collaboration with children's hospitals. They always do their best to support us. But again, when resources are stretched thin, there's only so much sometimes that people can do. So it's a huge challenge right now. And I think it relates to things like HHR planning and how we're going to ensure that kids across the country really have access to specialized services when they need them.
And in the past, I know when I've written about RSV, it's always been about Indigenous communities, places with poor housing. These respiratory illnesses are spread much more easily in these conditions that we see in the north.
Absolutely. We see a lot of overcrowding, people living in poverty, multi-generational families living together in poor conditions. When you look at the rates of Medivac for Inuit children from Nunavut, it's astounding for diseases like RSV. So the health equity impacts of some of these illnesses are really very different, and just the risk is different. And people's ability, right? We say things like stay home when you're sick or stay away from other people when you're unwell. Well, that's really challenging when you have 16 or 20 people living in a small home, all crowded together. So the impacts and the ability of people to make those types of decisions is much more limited in rural and remote parts of the country, for sure.
Wow. Fatima, if I could come back to you, I keep hearing things, I talk to people, I keep hearing a phrase I don't like hearing, things are going to get worse before they get better. Is that your sense too, that this isn't finished peaking?
Unfortunately, yes. And so we're looking at all these 3 different viruses, and RSV may be starting to plateau here in Quebec, but it's only because we started earlier than the other provinces. So it really depends on where you are in the country. So maybe in the next few weeks, RSV will start to plateau, but unfortunately, influenza is climbing sharply. And these other respiratory viruses are going to stay around all winter. So we're bracing for a really severe next 4 to 6 weeks, and likely driven by both RSV and influenza really across the provinces.
And we're going into the holiday season, more gathering, more opportunity for viruses to spread. It doesn't sound like it's going to be a very nice Christmas for pediatricians.
No, we're bracing ourselves. I mean, we're used to being busy over the winter months, but it's unlike anything really we've ever dealt with during the holiday season, where we're usually short on staff. So this is going to be an exceptional year with just the high volumes.
And Ronni, I wanted to for you to build on that, because this isn't just a problem of viruses. Staffing is a big issue. People have been stressed throughout COVID. A lot of people have left. We've seen a big exodus of workers. How can physicians and nurses and other health workers, how can they keep up with these seemingly never-ending crises?
Yeah, so I think we really have a bit of a perfect storm here coming together why this is so stressful. I mean, it does, however, start with the fact that the pediatric healthcare system all across Canada has been undersized for decades. So this system was never built to deal with volumes that we are currently experiencing. You add on then a little bit of the health care worker attrition that Andre referenced. And I think by and large, pediatric hospitals have seen less of those than adult hospitals. You add on that we have learned throughout the pandemic that you don't go to work anymore when you are sick, which is a good thing, by the way. Plus the fact that we are now competing with each other about healthcare human resources, because we are trying to train a lot more people, but we are really not in a position right now to have enough people. So that explains to you the crisis we are in. So there's the immediate solution is what's happening on the ground right now, everyone. We are working with our colleagues across like our regional system, but it's the same for everywhere in Canada. Wherever you have opportunities to work with the community, you work closer together than ever before, trying to support each other to get through this in order to protect the tertiary care that needs to be done at SickKids and many other children's hospitals across Canada. At the same time, not leaving our community pediatricians all by themselves, dealing with children that are all of a sudden much sicker than what they're used to take care of. And then I think it's about time that we all come together from a national point of view, even if not provincial, to think about how we're going to fix this. This needs fixing. Every time Andre puts some words around this into the newspaper, I'm always excited. It's just time for all of us, I think, to accept that we have a problem that requires fixing. And I think if from the federal and provincial government perspective, there could be a general acceptance and acknowledgement of that there is a problem that requires fixing. And I can tell you, I know I'm speaking on behalf of my colleagues here in Ontario, I double check that, that we will be willing, we are more than happy to work with you on that solution and be accountable to certain aspects of that solution. I think many of us have a very good idea of what needs to be done. But if others have better ideas, that's fine too. We just need to work on a solution, because without some significant changes to how we provide care between the continuum of tertiary care all the way down to primary care, family medicine, and pediatrics, we will find ourselves potentially in a very similar situation next year, and we should try to avoid that.
And you're not just saying we need more beds.
No. I do think it's an undersized system that requires certain investments, but I also think it requires restructuring of the things the way we are doing them right now. This is not just a money problem. In part it is, but not just. This has to be both. That's why I'm saying, if there's a general agreement on that we have a problem, then we can work together on how to fix it. There are lots of smart people around this table and around the country who can help work on a solution.
I think we pretty well all agree here we have a problem, so we'll focus on some solutions for the rest of the time. But Antonia, if I could turn to you, the viral illnesses, as we've heard, are the obvious problem, but can you talk about some of those ripple effects, the surgical delays, overwhelmed pediatricians in the community, and I imagine there are more.
Well, and it's all interconnected. When we have to cancel surgeries because we don't have beds in our hospital or ICU, that means delayed care for those patients. The pediatric population, thanks to innovation in care, which is amazing in the last 10 to 20 years, we now have so many children who live with very complex medical health problems. And so any delay in that care only worsens the severity for that population. One of the other crises that we've heard about a lot is the mental health crisis. And that was a problem. We were an under-resourced for the mental health capacity for children and youth, long-standing for years, but COVID really brought that to the forefront. So now we have these multiple challenges that are just showing us all these cracks in our system. And they're not insurmountable. Completely not, but we need to have a better understanding of where those problems are and exactly how to fix them. And one of the big gaps we have right now in our system is data across the country to understand exactly where those gaps are and how we can work together to fix them.
Yeah, we could do a whole other hour on data. That's a big one. Could you also address this issue? Pain medication is not available for parents either. How is that impacting your work?
Well, so that's really a challenge. I've had a number of, in my recent shifts, families coming in saying, I brought my child in, I can't get medicine for pain or fever. I'm coming into the hospital hoping that I will either have that medication or be able to provide a prescription for it. So that's really a big problem for families. And although we as healthcare providers may know that the fever itself won't hurt that child, patients and families don't know that. And so as soon as the child has fever, they become very concerned. And it's very frustrating as a parent. One of the few things you can do when your child has a fever or is in pain is to treat it. And now families can't even do that. And so that has a large impact on them coming to the hospital, on their personal frustration and their feeling of having any control over being able to take care of their children. So that's certainly something we felt the burden of, is patients and families who are unable to access these fundamental medications. Almost every child I see in the emergency department, I end by saying, give Advil and Tylenol for fever, pain, or comfort. And I don't even know how to say that anymore.
No. And we know Health Canada said late last week they're getting some doses in from the US, but it's still going to be a couple of weeks away. So there's a lot of angst to come. Katharine, if I could turn to you, we're hearing a lot of things that we should be doing. We should be stepping up flu vaccination for kids, bringing back mask mandates and more. But there seems to be a lot of public resistance to these pretty simple measures. Is that frustrating when you're sitting there in a room full of sick kids and people are saying, I'm not going to wear a mask or get a vaccine, can't be bothered?
It is really frustrating. And I think it just shows the challenge where we find ourselves right now, sort of socially, culturally, politically in this country. I think when you look over the course of the pandemic, what you saw is we moved from really, I think, a high sense of social cohesion at the beginning of the pandemic. And as we've moved through and to the stage we're at now, what we've seen is a lot of these issues have become very polarized. We've seen the role that misinformation has played in terms of polarizing society. I think we've seen, essentially we've had a country that's experienced a collective trauma and everyone's reacting to it differently. And there's now a lot of pushback around things like basic public health precautions like masking, staying home when you're sick, and also vaccination. And we've seen that, I think, with the COVID-19 vaccine, dwindling uptake as you go down the age groups from children, from adolescents to younger children now to the 6 months to 5, the uptake is just progressively lower. We don't have data right now on the exact uptake of the influenza vaccine for children, but just in general, we've seen that there's more and more sort of, I think, resistance or concern around vaccination. We know children have fallen behind in their regular vaccines. 1 in 4 Canadian children is behind on those routine immunizations. We know that. So I think we find ourselves at a very challenging place, and how to best be communicating with the public, how to share these ideas, and how to move past this polarization that I think is driving people away from things that could be useful right now. And it is really challenging seeing that when we're now facing all these pressures in hospital. And really what we're trying to do is get people to come together to say, these are simple things we can all be doing. Do you have to wear a mask all the time? No, but please wear one when you're in a crowded indoor space. Please don't send your child to school when they're sick. Please be up to date on your vaccinations. These are really simple things that if we could get some collective action around that, I think we could see some improvement in the current situation, but we're struggling. And I think it really does just speak to the cultural moment of where we're at and the impact of polarization and what it's done to us as a society.
And none of these things will magically end the crisis, but they will alleviate some pressure, I guess.
Absolutely. And I think that's what's important to understand, as Fatima talked about at the beginning, part of why we're here is we really have 3 cohorts of children that are all being exposed to viruses all at the same time. And what we're really trying to do is slow that down. We live with viruses. These viruses are part of our world. They're not going away. But what we're trying to do is, of course, protect the capacity in the healthcare system, try to protect especially young children who are particularly at risk of severe illness, and sort of slow those waves. Certain other positive things are on the horizon. There's some research now around RSV vaccination that may be coming. That will be a game changer for pediatrics, much like all the other childhood vaccines have been. So there's things that are hopeful for the future to protect children, but right now we need to use the tools we have to try to slow the spread so that we're able to keep up with the demands in our hospitals and make sure that children are getting access to the services that they need.
Fatima, I want to come back to a little bit more technical stuff to help people understand what's going on out there. We hear terms bandied about like immunity debt and immunity robbery, and people saying kids are getting sick because they didn't get exposed to enough germs, and other people saying they're getting sick because COVID has hurt their immune system. Can you help us sort this out? All these contradictory things. What's going on?
This is really important. And I know I'm hearing these terms out. And so I think the first important point is to say that children's immune systems have not changed. So there's no underlying immunodeficiency. And I say this with as much certainty as I can as an infectious diseases doctor, looking at the data, but also looking at the kids who are hospitalized and how they're evolving with their disease. There's really no sign that there's a change in their immune system. What's happened, unfortunately, is that many children have not had these viruses. And so the first time you get it, it's the most severe. And as Dr. Smart was saying, we have 3 years worth of children that weren't exposed to these viruses. So when they get them the first time, it really triggers a severe illness. The second, third, and fourth infection are less severe. So kids are getting infection after infection after infection because they haven't seen them, but it's not that their immune systems have changed. It's really just a matter of being underexposed. And I'll often explain to parents, it's very similar to what I used to see in my practice pre-COVID. So every October, November, I would get consults after consults for parents whose toddlers had just started daycare. And so they were worried that something was wrong with their immune system because they were getting cold after cold after cold, or fever after fever. And in 90% of those situations, we would watch and wait, and within the next year, that child is entirely fine. So it's really unfortunate that it's all happening among all of these children all at the same time. But I want to reassure people that there's no signs that there's anything wrong with their immune systems based on all of the data we have available right now.
And when I hear people say, well, it's a good thing for kids to get sick, it's good for their immune system. Is that true? Is it good for them to be getting sick?
No, it's never good to get sick, specifically because, there's a chance that it can be severe. And as Dr. Cohn was saying, we don't know, but some otherwise healthy children can have very severe illness. But unfortunately, these viruses are a part of our life. And so over our lifespan, we will get them sequentially. The idea is to not get them all at the same time, and hopefully to be as protected as possible when you do get them. So when we have viruses that we can vaccinate for, when you encounter this virus, you won't be as severely affected. So it's never good to have an infection, but this is part of life. So the idea is to, when you get it, you're as protected as possible.
Great. And Antonia, just a question from a senator. interested in how can we have better messaging for parents? What should we be telling them now? There is a lot of contradictory messages. It's often hard to sort out. What's the message you need to hear?
Yeah, well, I think that's very important. And I struggle with that a little bit because we want to be careful with our messaging that we also don't provide so much messaging out there about how busy the emergency departments are that patients and families with really sick kids are scared to come. So I think we have to find a balance with our messaging. But certainly there is a lot that patients and families can do at home and access. Most provinces have either telephone lines or online resources where they can look to guide their healthcare choices, because it's really about determining what your child has and what the best resources are. And is it a visit to a family doctor, an urgent care center, a pediatrician, or the emergency department? And just making sure that patients and families are aware of the resources that exist in their environment. We talked a little bit about using Advil and Tylenol and comfort measures. Even when Advil and Tylenol aren't available, there's a lot we can do to comfort our children with fluids and a lot of things that parents can do just in terms of comfort and care. So I think being very clear on our messaging about the alternatives to care, about the things patients and families can do, and just making sure that when patients and families do need the care provided at an ED or a children's hospital, that they know when and how to access that.
And I think your earlier message, don't stay away from the ER because you're scared, is important. Kids can get sick very, very quickly, right? They can go downhill very, very fast.
Yes.
Now, Ronni, in the previous intervention, you were talking about, the need for systemic change, that some of this stuff has been building for years. What's the single most important thing pediatric hospitals need right now to help them?
I actually think that right now, we probably have all that can be done in the current situation. To tell you the truth, I hope it will be enough, and I'm an optimist always and will always be that I think it will be enough. What I think we really do need, though, is an expeditious coming together, whether that is provincially or federally or both, to talk about some of the issues I was talking about earlier. That need to be fixed, that can be fixed, and they cannot be done in isolation. You spoke about the hospitals now, Andrea, and I appreciate that the hospitals are currently somewhat of the backbone to this crisis management, but I see the question from Senator Kutcher there around what the federal government can do. I will be fully transparent and share with you an idea that I put to Minister Duclos when he called me about the Tylenol and the Advil coming to Canada. I don't know how politically feasible it is, but maybe there's an opportunity for the federal government to specifically focus discussions on the pediatric healthcare sector. I can tell you that in Ontario, we have come together as a sector between not just the children's hospitals, but with the mental health agency, with our rehab agencies, and we have worked on what we believe is a solution to the problem. That's not to be said that it can't be tweaked by any stretch of imagination, but maybe there's a way for the federal government to say, we recognize there's a problem in pediatric healthcare, and we want to work with the provinces to address the pediatric healthcare system. And we as pediatricians, I will say, if that happens, will be accountable to whatever you put into place, because the other question here around metrics is there are metrics for volumes, for wait lists in all the sectors, and we can be held accountable to those if we can put the solutions into place that really connect the entire healthcare system and are not just focusing on hospitals per se.
And Katharine, you've met a number of folks in the audience today, senators and elected officials and their aides. Tell them what can make a difference right now. What would you like to see happen right now that they can influence?
Yeah, thank you. I think so many of the themes that we're hearing about in the healthcare system are the same, right? It's the lack of a pan-Canadian strategy. We do not have a pan-Canadian strategy for children and youth, and that's essential. And I think you're hearing that from various stakeholders on this call. We need to understand what the challenges are, and we need to work collaboratively to create a plan of where we're headed. I agree that I think in the short term, it's very difficult. We are really deploying the resources we have, but part of our problem is we have not made a plan of where we are right now and where we're going. So within that strategy, I think we need to be looking at our human health resources. That includes both pediatricians, but also other experts in child health, how people are being trained, what skill sets they have, where they need to be deployed, and where they're needed, and understanding that. We've heard a bit about data strategies. That's of course important, so we can understand what's going on, track our progress, track the outcomes of any new interventions or ways of doing things that we may do. I think it's also really important. It's something we haven't talked a lot about today because we're talking a lot about hospitals, but you heard Emily talk at the beginning about this concept of better beginnings. And I really want to just focus on that for a moment. We know that the roots of adult disease start in childhood with adverse childhood experiences and trauma that children experience. And these adverse experiences inform both the genetics of how they experience physical disease, obesity, chronic medical conditions, heart disease, hypertension, all of the diabetes, all of these things that impact our system later on, as well as mental health problems. And we know that those early years, those first 5 years of life are critical to your future development and your future health. Yet we do not have a strategy in this country to ensure all pregnant women and their newborns are supported and that those families are supported. And I really see that also in my work in the North, where there's a lot of intergenerational trauma and of course the impacts of colonialism. And we need to understand that to get at that issue of what I'd like to call health versus healthcare, why are some children healthy versus others not? It's really those fundamental pieces. We still have over 12% of children in Canada living in poverty, despite the richness of our country. So I think as part of our pan-Canadian strategy, we also need to really understand what are the root causes of health. Where can we make those family-centered interventions? We need to be able to look at children in their families and communities and make sure that the supports that we're developing are holistic around those units, and try to prevent those early adverse childhood experiences that then impact those children throughout the trajectory of their life and are a root cause of the chronic illness that we see in our hospitals. So that lens of prevention, I think, is really, really critical as we look forward also. That's of course longer term, but the dividends there I think would be massive. So I think it is really getting leaders to the table. It's creating these strategies that, on this call, you've got lots of people that have done a lot of work and have a lot of ideas, but we need to really, I think, move past the politics. And I think that's what we're all feeling frustrated with right now, especially with the recent failure of the provincial and federal conversation, is this, kind of doubling down on it's all about the money, and no, it's not. We all know it's a bit of both, right? We know we're spending a lot of money. We know we're not seeing the outcomes in our healthcare system we should be having. We know there's a lack of accountability. We need to, I think, move into the real dialogue of what sort of transformation needing to happen. I think the advantage of children's health is it's smaller than adult health, and there is a lot of consensus and collaboration across experts in child health that I think could really allow us to move forward with the strategy probably quite efficiently. And in general, in pediatrics, most people are very nice and agreeable, and they all want to do the right thing for kids. So you don't sort of run into maybe some of the same challenges you can see with other people, not to disparage my adult colleagues, but that's why I chose pediatrics. So I think there's a huge opportunity here in front of us to really think about some of these longer term challenges and really design a system for the future. And like Ronni was talking about, it's got to span everything, right from families and the community to community health providers, all the way up to the tertiary services that children rely on as well.
Yeah, we certainly have nice and agreeable people on this panel, so you're a good representation of the profession. Antonia, I wanted to come back. I want to give you a chance to elaborate a bit on the data question, because I think it really is an important one. It was a key issue in the recent federal, provincial, territorial meeting. Can you talk about why data is important? The public might think, who cares, just numbers, but...
Well, and I think Katharine alluded to this, that when we start to make improvements in a system, we don't know that changes are changes are actually improvements unless we have the data to show it. Data is important to show us where we are today, where we want to go tomorrow, and have we achieved it. And it's not about necessarily always more money, it's about spending money in the right places. And that's what data allows us to do. And I see someone has asked about key national performance metrics. And there's lots of metrics we could use. What I would say is that often the metrics we use in healthcare don't always apply to pediatrics. That's certainly true in a lot of metrics I know in the emergency medicine area. And so I think what I would ask of this group is that as we begin to look at national metrics and data, please include pediatrics and child health in that, and recognize that some of the metrics that are important to us that are really meaningful may not be the same as are important for adults and adults' health and healthcare.
So give us some example of important pediatric metrics.
Well, some of the things that we talk about in pediatrics, it's not always about mortality, it's about quality of life. And it's about talking to patients and families and engaging them on what are the metrics and outcomes that really matter to them. Because, what often gets people excited is mortality. And when we talk about kids, often we don't have the same kind of mortality numbers that they have in adults, but we sure have a lot of quality of life issues and access issues that are equally important when you talk to patients and families. So I think it's important to recognize exactly that there are going to be key differences in what those metrics are going to be, but that doesn't make one metric more important to measure than another.
Yeah, and certainly I always use the line that children shouldn't die, right? We shouldn't make mortality the important thing. It just shouldn't be happening in this day and age.
Agreed.
Fatima, I wanted to come back to you and give you that opportunity to answer what Senator Couture was asking about. What do you want the government to do right now? Are you someone on the front lines? What would help you out?
So I think what we mentioned earlier is accessing these medications. So Tylenol, ibuprofen, those shortages, and I'm glad that those are going to be on the way. There's also issues with antibiotic shortages. So we've run out of liquid amoxicillin and liquid clavulin, which are the two most common and most effective antibiotics used for children. And, just securing that pipeline and ensuring that we don't run out of these. We're hearing also word that we're going to be running out of other medications in the near future. So we're really panicking on the pediatric side, scrambling to find alternatives, but it's important to realize that children need formulations that they can take. So as much as there are so many adult drugs available out there, children can't swallow pills, and the taste of many of these suspensions are a barrier to taking them. And so there's been a lot of movement recently to try and really encourage pediatric formulations, get these formulations, and really encourage drug development in this area. And so that's one huge area that I think, just looking ahead to the next few months, the next few years, working on these antibiotics and these drugs and making sure we have them available. And then also just, the pediatric vaccines and the pediatric treatments, again, they lag so behind when it comes to adults. And we just look at the example of COVID, where vaccination was last on the list for children. Children's therapeutics still don't exist, and we're extrapolating from adult data, whether it's remdesivir or Paxlovid. We don't even have decent antivirals for children. So the whole field of pediatric treatments, whether it's research development or access to them, is one that I think we could really accelerate at a governmental level.
And the other thing I want to ask you is, we're focusing on all these respiratory illnesses, but all the other stuff that kids go to the hospital for usually is still happening, right? We can't forget that.
Oh, absolutely. And I think it's a huge issue, as we were mentioning, the mental health crisis in parallel. So all of these children are taking up hospital beds. And then, of course, they have these respiratory issues, but they can get these really severe bacterial infections after the fact. So it's a surge of things. It could start as respiratory illness, but we're getting multiple complications from multiple diseases, in addition to all the children with their routine care that need hospitalization.
And Katharine, another question, and I'll remind people there's still time to ask questions, a few minutes, but you still have an opportunity. Katharine, there's one in there about, are there areas that impact Indigenous children harder that you would bring up that the audience should be aware of?
Absolutely. I was speaking earlier about adverse childhood experiences, trauma, poverty. We know that Indigenous children, of course, are much more impacted by all of these things compared to other Canadian children. So those things are huge in terms of their health outcomes. Of course, we have the challenge of huge geographic distribution and many Indigenous children living in very remote communities. So access to care is really challenging. Access to culturally sensitive care is also another challenge that's important to understand. And again, I think the ability to provide care to Indigenous families as a family unit is also often very challenging. So there's a lot of work, I think, to be done to partner with Indigenous leaders and families around how how to appropriately deliver culturally sensitive care to their communities. And I think we need to really be showing up in those spaces as learners and listening about how we can decolonize healthcare. A lot of the ways that we ask questions and provide care can be very sort of provider-centric rather than family or community-centric, and the impacts of that can be very negative in terms of creating rapport with Indigenous families. So I think that we have a lot of work there to do. I think we also have to understand, again, with these surges, what that's like for some of these rural communities when all of a sudden many children are sick at the same time. You know, I was just talking to a colleague who's a pediatrician in Thunder Bay, and they had the scenario where they had one of the reserves nearby that they take patients from. You know, they had a massive RSV outbreak. They were needing to medevac, 6 to 8 infants to Thunder Bay. But the response they were getting from the hospital is, well, we don't have beds. So if we don't have beds, we won't accept the patient. Well, this, again, these are impacts that are unique to Indigenous communities that are dependent on medevac. No one else is prevented from showing up to an emergency department if they're ill. But when we're saying things like, we won't move your patient because we can't provide an inpatient bed for them, well, what are these nurses supposed to do in these rural health centers with these very sick children? They're dependent on being able to move those kids to a higher level of care and where there's a physician. So it's these types of biases in the system that really impact access. It's that lens that people are applying a different lens sometimes to the services that Indigenous children receive versus non-Indigenous. It's that recognition that certain communities are dependent on medevac services to move to a hospital, whereas other Canadians can just pull up to the front door and walk in the emerge and would never be denied services. So I think we really need to be thinking about all of those things when we're thinking about how to best serve Indigenous children and families. And then I think, on a go forward basis, we also think need to think about how do we bring more Indigenous children and youth into healthcare and into the healthcare profession so that they can provide that care to their communities and allow all of us that are already working in healthcare to do better and to see that representation.
And Dr. Stang, we have another question from Senator Couture. He's reminiscing about some very horrible things he underwent as a child. But aside from that, his fundamental question, are there non-medical interventions that parents can take to lower fever? We know fever can be a bad thing. It can also be a good thing for children. But what should they be doing if they can't get the Tylenol?
Yeah, no, I think that's a great question. I think one thing we need to normalize for patients and families is that fever is a sign of a body fighting an infection, and an otherwise healthy child, most of the time, fever isn't going to hurt the child. We medicalize it because when you come to the emergency department, we measure your temperature, we ask how long you've had fever, and that's not because a certain temperature is too high. It's more just part of the clues we look at in medicine, but we need to unmedicalize fever a little bit and just reassure families that in most children who have a fever that lasts only a day or two, who is otherwise well, the fever itself is not really an issue. And I think that's important. Fluids, an adequate temperature in the house. We need to be a little bit careful about some of the alternate messaging. We're hearing some messaging about giving adult formulations and how to do that. And so I think we need to be really clear in our messaging. And I think the first step is probably normalizing fever a little bit that in a normal, otherwise well child, it's not something that we need to be as concerned about as we are.
And Ronni, we just heard, information. It's hard to get good information to parents. What role has misinformation played in what's going on here? There's a lot of, as I said earlier, lots of confusing messaging going on there, and some really deliberately false, even from anti-vaxxers.
Oh my God, I don't even know where to start around the misinformation. This has been such a difficult problem for all of us, as much in the healthcare system as I'm sure for you, Andre, as part of the group of people who actually tries to provide the right information. Somebody said early to me in my career, there's one thing, if I can tell you one thing, you can never over communicate enough. And I think that's probably true. So whenever there's false information out there, we need to do our best to correct it. One of the first questions around the emergency room wait times, parents don't really even understand that every child that needs urgent care and treatment actually gets the care. The reason, when you hear about families waiting 12, 18 hours, these are children who shouldn't be coming to an emergency room and who should be seen in a different kind of setting. So I honestly don't know how to fight misinformation other than by perseverance of providing on an ongoing basis the right information.
Right. And we have a question from, I was going to say doctor, but now Senator Osler, who's joined us. Thanks for being there. And maybe I'll throw it to Katharine just for fun. You're both CMA alumni. I'll reframe her question. Why don't we have a pan-Canadian strategy at this point? We've talked about it for many years. Why haven't we acted on it?
That's the million-dollar question, really, isn't it? And that would, I think, apply both to children and youth and more broadly to Canada as a whole. We have lacked a pan-Canadian strategy around healthcare, I think, in general. I think it's a challenge of our federal politics. You know, we've got the federal government, of course, is a major funder of healthcare, but the responsibility being largely provincial and territorial. So we have those siloed systems. And I think there's been a resistance to want to recognize that a lot of the issues that the provinces and territories are facing are the same and the priorities are the same. And there's probably a lot to be gained from creating a cohesive strategy and learning from things that have worked or not worked and scaling those things that are successful. And I think some of it's also, you know, the model of what our healthcare system is or what healthcare is. You know, again, we have a bit of a myth around universal healthcare. It's really a universal insurance policy, covers physicians and hospitals. It's not really a universal healthcare system. And that, of course, applies for children as well. You know, we're talking about the mental health crisis, where many of the mental health resources are not part of what's covered in our healthcare system. So I think we really are in a moment where what our healthcare system is, which was designed in the 60s, has been far outpaced in terms of what it needs to deliver to Canadians. I think we need to recognize that the issues are essentially the same, province to province, territory to territory, with a few small differences, but the broad challenges around HHR planning, staff morale, pan-Canadian data structure, you know, the issues we're seeing around children, early beginnings, the need for better childhood research, the need to be able to meet the needs of increasingly complex children and adults. Those are the same across the country. And now I think is really the moment for us to come together and move past the politics of this into solutions. And, you know, why haven't we done that? I don't know. I mean, this is what's so kind of gobsmacking, I think, at times, is we've been talking about a lot of these challenges for years, 20 years, some of them, you know, things like primary care, integrated team-based care. These are not new ideas, but we haven't executed on anything. And I think there's just perhaps been a lack of will. I think it's challenging because in a lot of ways, healthcare is sort of that sacred cow in Canada that I think people are a bit afraid to talk about change, because the conversation can deteriorate from there into people thinking we're talking about, you know, Americanizing our healthcare system, which of course no one thinks is a good idea. But I think we really need to acknowledge where we are, admit that the system is failing. It's clearly failing Canadians. Access to care has never been worse. You know, like Ronni was saying, a lot of these long waits are because people are in the emergency department where they could be getting care somewhere else, but that care is not available either. So that's why people are there in a lot of cases. So, you know, never waste a good crisis. I think this is where we are. The opportunities in front of us. I think there's a lot of consensus around what needs to be done. And now I think we need the will and the courage to lead and to make those changes, to engage the public in that conversation, but to take those first few steps. You know, let's pick 3 to 5 things and let's do something. Let's stop talking about it. And I think that's really where we are right now.
Can I just add one thing to this, please? I'm sorry. Yeah. You know, Andre, I don't think I've ever found myself not agreeing with you, other than when you said earlier, I think we all agree that there's a problem. Mm-hmm. I have to tell you from my personal experience in interacting with government and non-government people, I'm actually not sure that everybody agrees that we really have a problem. Mm-hmm. And I would ask all of you who are listening today to maybe go away and accept it, because then if we accept it, then everybody should recognize that any of the things that are happening currently in the pediatric healthcare system are unacceptable for a country like Canada. And if we do that, then we can work on a solution. So I hope that's okay. That was my passionate, tired plea to
yeah.
Great. And I think, and we're almost out of time, so I think that's a good note to end on, but I want to give a final word to Senator Moodie, who's organized this, send us home. I know you all have busy schedules, so I have to end right on time, but Senator Moodie, a few final words.
Thank you very much, Andre. And Ronni, I would agree with you that there is still work to be done to light the fire. There is a problem and there isn't unanimous agreement that there is a problem. Although many of us are like-minded, we have
amongst parliamentarians and amongst legislators. We need to light that fire. I want to thank the panelists for joining us today, and the participants for giving us your time, your questions, and engaging on this topic, very important topic. I wanted you to know that we have recorded the session, and the recording will be available so you can reflect in more detail on some of what has been said. Just reach out to my office and we'll happily share. Let's keep in touch for more discussions, because I think it is going to be important for us to pull together that common ground, the agreements that we have, that we can move forward, the commitments that we already have, so that we can certainly move the needle on this. I will certainly keep fighting this fight, if you will, to use a hackneyed term, but I think it is important for us to continue to have this dialogue. So thank you all again for joining us, and we'll certainly convene future discussions. Thanks, Emily, for helping us make this happen on such short notice. Thanks a lot, everyone.